Okay, very good morning students. So welcome. Today we'll start the Inicet and Neet PG Psychiatry one more final session. Within this final session we will finish most of the final topics which are very much important for Inicet as well as Neet PG. So today we will discuss something about opioid and opioid poisoning as well as dependence, right? Opioid poisoning as well as dependence. First of all, most of the students and even most of the people don't even know what actually differentiates poisoning from dependence, right? See, for example, there is an individual named X. He is an individual. For example, he usually takes a dose of opioid. So he is completely habituated for that opioid. But after a period of time, so he just wants to get rid of that habit, but is still completely dependent on that thing. So he comes to the OPD. So he just gives the complaint. He just gives the whole history of opioid consuming since the past 3 years or 4 years or 5 years. So he himself comes to the OPD for the treatment, right? So we are giving treatment for opioid dependence, right? That is a opioid dependence. But if a person of X, he doesn't take opioid continuously or something like in a day-to-day manner, but suddenly he consumed an opioid for something like, for example, you take it as morphine 80 milligrams or 80 micrograms or 40 micrograms, something he has consumed, opioid product he has consumed. Suddenly it led to opioid poisoning, something like you observe pinpoint pupil as well as a decrease heart functionality, or you can also see tachycardia in some instances, but most of the time you observe bradycardia, as well as there is an increased secretions, it appears like drooling, etc. So if it comes with the symptoms like that, so obviously it is taken as a case of opioid poisoning. So ultimately it holds a different treatment. So that is the difference between opioid poisoning and opioid dependence. Dependence is someone who takes or consumes opioid day-to-day manner, but there is a similarity, there is a slight logic that even a dependence case can come to you with a opioid poisoning complaint also. Why? Because, for example, this person who is opioid dependent, his body can tolerate only something like 20 micrograms of opioid dose, but suddenly he consumed a dose of 60 micrograms. Ultimately it lead to poisoning. So he also can come to a OPD with a complaint of opioid poisoning, but mostly the scenario is seen like this only. Means if a person is already an opioid dependent but he comes to the OPD, he wants to get rid of that habit, so he gives a complete history of his previous opioid dependence. So regarding the history itself, you will just go through the history and you will give a perfect treatment to him. Or if a person is just an occasional opioid abuser, so suddenly he took an extra dose or double dose or triple dose, he come to the OPD with a complaints like secretions from the mouth, drooling, pinpoint pupil, all sort of these complaints is arising, and he is brought to the OPD. Actually he will not come to the OPD, he is brought to the OPD by his relatives or friends or something with these complaints. Then you will give opioid poisoning treatment. So that is what happens while you differentiate between opioid dependence as well as opioid poisoning. Now coming to the treatment of opioid poisoning is one of the fan favorites of INCT profs, trust me, because I'm not saying it like north side most of the youngsters have an increased opioid intake, even south side also you have increased opioid intake, but most of the cases, maximum amount you observe in the north region only. But I'm not pointing it out, but the census or the stats itself speak that. Okay, so if you take Delhi, all those some sort of areas which are highly developed, highly established regions, so you see most of these cases of opioid abusers or opioid poisoning cases. So we'll just start with the treatment instead of all this history. We don't want history, we only want treatment. So for example, the patient comes or is brought to the OPD with a clinical features of unconsciousness. This is very much important. You please note down all these things, because the case history or the case complaint in the MCQ, it will be written in the same way, right? So there will be a respiratory depression, as well as there will be pinpoint pupils. So what is the drug of choice for opioid poisoning? Most of the doctors still have a confusion that, sir, whether it is the naloxone or naltrexone as the drug of choice for opioid poisoning. Some people are saying naloxone, some people are saying naltrexone. No, IV naloxone is the drug of choice for opioid poisoning. Always remember, IV naloxone is the drug of choice for opioid poisoning. But remember, naloxone can not only be given as IV intravenous route, it can also be given as a nasal spray. Now after this, if you come to management of opioid dependence, if you discuss about management of opioid dependence, then obviously you can see a little bit of differences from opioid poisoning. You just check it out. The management of opioid dependence takes place with the first drug being methadone. Always remember, management of opioid dependence includes methadone. What is a methadone? What is its mechanism of action? It's actually a long acting agonist. And one more important thing that you should remember about methadone is it has one potential side effect, that is abuse potential. For example, if the patient was given with methadone as a treatment for dependence, chances are there the patient might get addicted to it, or the patient might use it as an substance abuse, right? So methadone has its own side effect. Now coming to the second important drug, that is buprenorphine. Second important drug for opioid dependence is buprenorphine. What is buprenorphine? Buprenorphine mechanism is a partial agonist. Why some of the doctors are dropping me a question, sir, long acting agonist, which agonist? Okay, I won't tell this answer, you just drop it down in the answer comment section, right? So what actually I mean by long acting agonist? You only just write the answer, right? So buprenorphine is a partial agonist, right? Just 1 minute. Buprenorphine is a partial agonist. And one more thing is, when compared to methadone, buprenorphine has less abuse potential. Remember this fact, buprenorphine has a less abuse potential. So you can prefer buprenorphine over methadone. But one more important fact is, buprenorphine can be utilized as a sublingual drug. What is the most important sublingual drug that can be given for angina? Just 1 minute. Slow drip. So what is the most important drug that can be given as a sublingual for angina? So please drop it down in the comment section, right? So buprenorphine is a partial agonist and it has less abuse potential when compared with methadone, right? So we'll compare to the next drug. Next drug is an important drug to just remember, that is naltrexone, right? So naltrexone. So now you can get to know what is the difference between naloxone and naltrexone. Naloxone is an emergency drug which is used for the drug of choice, IV route for a opioid poisoning, whereas naltrexone is a opioid antagonist which is actually used for opioid dependence. Remember this is very much important. And one more thing is, it can be used for long term maintenance therapy. It can be used for long term maintenance therapy, right? And one more thing is, it can be a beneficial sometimes, or it's just a casual thing. It can be taken as a oral form. Remember, it can be taken as a oral form as well as depot preparations. See, I'm just making a cut short notes. Don't get mugged up. Don't just dump unnecessary things. Only things which are necessary for the examination point of view only. You just go on with those things only, right? If it is naloxone, it is given as IV, drug of choice for opioid poisoning. Okay, remember that one. If it is given about naltrexone, it is an opioid antagonist. It can be used for long term maintenance for opioid dependence, as well as it can be used both in oral form as well as the depot preparations. Okay. So we finished off with the opioids, right? So we'll just go back, we'll just clear it off. I think opioid poisoning and opioid dependence is finished. But if anyone have any sort of doubt regarding the mechanism, and I just ask you to drop the mechanism of action, so called, the first one is partial agonist and second one is antagonist, and you can just drop it down on which receptors these drugs act in the comment section. I will just check it and tell whether you are absolute or not, right? So let's come to the next topic, that is personality disorders. I heard nearly for the last previous INCT 5 years papers you take, 3 years papers you got a question on personality disorder. It's actually an integrated question. It's not a direct question, but it is an integrated question. Okay, it's an integrated question, remember, right? So we'll just start with the personality disorders. So actually, before talking about the personality disorder, we should look into the first big 5 personality factors. There are 5 big personality factors that we should get into it. You can just simply remember with the mnemonic OCEAN, right? So ocean. So the first personality factor is openness, something we just simply exploit to outside in the form of verbal relations, right? Second one is consciousness, right? Second one is conscientiousness. Third one is extraversion. Fourth one is agreeableness, right? And fifth one, final one is neuroticism, right? Neuroticism, right? So the first one is openness, conscientiousness, extraversion, agreeableness, and neuroticism, right? Now if you come to the next one, there is actually clusters of personality disorders. The personality disorders which can be with the verbal occurrence of clusters of personality disorders. See, these all are short and sweet things that you can remember easily, right? No need to mug up everything. You just simply remember these things, understand, you can easily get those MCQs perfect, right? There are actually 3 clusters if you want to get into it. First one is cluster A, second one is cluster B, and third one is cluster C. Alright, cluster A, cluster B, and cluster C. Cluster A is odd and eccentric. Cluster A is odd and eccentric. Cluster B is emotional, dramatic, and erratic. Emotional, dramatic, and erratic, right? And final cluster C is anxious and fearful, anxious and fearful or fear. Okay, so what comes under cluster A? I'll just underline these things. You just remember these clusters and their digits, right? So what comes under cluster A? That is paranoid personality disorder, PD. I'm writing PD shortcut for personality disorder. Second one is schizoid personality disorder. Third one is schizotypal personality disorder, right? Now coming to cluster B. Cluster B consists of borderline personality disorder as the first one. Borderline personality disorder is the first one, followed by histrionic personality disorder. Third one is narcissistic personality disorder. Narcissistic personality disorder. And final one is antisocial personality disorder. Always remember, this final one mostly is given in the MCQ. Antisocial personality disorder comes under cluster B, which is emotional or dramatic and erratic, right? So antisocial personality disorder comes under cluster B, and schizoid personality disorder comes under cluster A. Schizotypal comes under cluster A. Remember these things because these are very much important. Mostly MCQs comes around these options only. And cluster C consists of OCPD, which is shortcut for obsessive compulsive personality disorder, or also called as anancastic personality disorder. Please write this in brackets, anancastic personality disorder. Remember, anancastic personality disorder. And second one is dependent personality disorder. Dependent personality disorder comes under cluster C. This is also very important. I think in previously 2019 Neet PG question paper, I think this was given. You just check it off. Next, anxious avoidant personality disorder. Anxious avoidant personality disorder. Previously we already discussed cluster C consists of anxious and fear. Anxious and fear oriented conditions, that is anxious avoidant personality disorder. So these are all the personality disorders that you should go on with it, right? Now we will discuss something about borderline personality disorder. Borderline personality disorder. This one is important for Neet as well as Inicet, but most probably this time I am expecting in Neet. I am not expecting this one in Inicet because in the previous 5 years of pattern, if you analyze it, I am not expecting from BPD in Inicet. Mostly you may get from mania disease, mania conditions. You may get a MCQ most probably, and if not, you can from schizophrenia also. I am expecting a question in Inicet. Regarding Neet PG, you will surely get a question from borderline personality disorder. So please get on with this topic as perfect as you can. Borderline personality disorder, also it can be called as emotionally unstable personality disorder. Remember this is very much important because you might be given with a question like a female of age 21 years came with a complaint of so and so. She is emotionally unstable. Or the clinical features will be given like which indicates that she is emotionally unstable, right? Now thoughts. Simply these patients see or observe the things as extreme. They are simple, but these patients, they just observe it like extreme, that is splitting or black and white thinking. right? Splitting or black and white thinking. Actually, I just want to define a 5 minutes class or explanation about this black and white thinking, but I just want to ask you whether you students know about this B and W thinking or not. Most of the times we use this condition in normal talking also. This girl has a black and white thinking, that boy has a normal thinking of black and white nature. So we just used in a normal language also. I just want to know what is meant by black and white thinking. You please drop down in the comment section. Okay, so they just just make it like a black and white thinking or splitting, or sometimes they also exhibit all or none thinking, right? And one more thing called dichotomous thinking, right? Dichotomous thinking. Now these patients, they just simply exhibit with a parasuicide or deliberate self-harm like or non-suicidal self-injurious behavior. In shortcut, you can just make it like NSSI, right? NSSI. And if you ask me what is the most common type of NSSI, surely you will observe the patient with complaining of slashing the wrist. Mostly they commit suicide with a slashing of the wrist, right? So you can also denote it like they are more prone to develop one of the favorable condition, that is bipolar disorder. Chances are there that these patients may land up with bipolar disorder. So if you just ask me simply, sir, what is the treatment for this condition? It is as simple as like that. It is called, I will write a shortcut form, but I will tell you, it is DBT. What is DBT? Dialectical behavioral therapy. Remember, this is the treatment for borderline personality disorder. Please remember these words, remember these names. Don't get confused in the exam. OCT, OBD, DBT, all these names please remember in the exam, right? So with this we finished borderline personality disorder. We will come to something about the mind and its defense mechanisms. Mind and how the mind uses its tips and tricks to produce some defense mechanisms, right? So we'll discuss some mind and defense mechanisms. Most of the time, any person's mind usually defends himself with the help of ego, or also called egoistic nature, right? Now if you ask me what are some of the mature defense mechanisms, generally which sort of mechanisms these grown-ups or some mature defense mechanisms are observed, right? You can just remember with the mnemonic HAAS, right? HAAAS, HAAS. First one is humor. Second one is anticipation. Just remember this, it is very much important. Third one is altruism. Fourth one is asceticism. Fifth one is suppression. All right. Suppression is actually a conscious defense mechanism. Remember, suppression is a conscious defense mechanism, and finally sublimation. Okay, so these 5 features you should remember, right? 5 or 6 features you should remember. So humor, anticipation, altruism, asceticism, suppression, and sublimation, right? Now there are actually two theories for this. First theory is called topographical theory. It was named like that, topographical theory. Nothing much history behind it, but it was just named like that. And another one is structural theory. See, the name itself denotes their explanation. No need to by heart, or no need to just mug it up, right? So what is topographical theory? In this, mind is divided into 3 components: conscious, preconscious, preconscious, and unconscious. Okay, so that is all about topographical theory. But if it comes to structural theory, mind is divided into different components like ID. That means in this state the patient is completely in an unconscious part of mind. Right? That's ID. Another one is ego. Right? And another one is super ego. Now these two things, right? These two things can be visualized in all the 3 aspects of mind. Okay. Now we will discuss some of the defense mechanisms in some disorders. We'll just look into it. What actually do they look like? Right. Yes, we'll just write the name of the disorder here, and we'll check the defense mechanism here. Now what it is like in case of a obsessive compulsive disorder. Generally they exhibit a defense mechanism like undoing, or sometimes you can also see reaction formation or isolation, right? If it is in case of a phobia, fear like disorders, you see some things like projection type of defense mechanism, or you can also see avoidance of a particular component which may project into phobia. So displacement, right? So these type of defense mechanisms are observed in phobia oriented, fear oriented state, or in some other disorders like psychotic defenses. What sort of things you see? Projection type of defense mechanism, or denial, a simple denial of the fact, or it can be even distortion also. The patient may also exhibit with a distortion like state, right? So remember these things, these are very, very important. just 1 minute. So these are the things that you should remember. Okay, yes, so just check it, all the things, then we can go on with the next thing. So we will discuss after this finished. Okay, so we will discuss some of the therapies, some of the treatments, and what are their uses, some of the list of therapies and their uses. This side I will write the name of the treatment, or we can simply write the disorder, and this side we will just write the treatment or therapy. Right, now the first one is depression. If you come to depression, most of the times we deal with the treatment like CBT, cognitive behavioral therapy, or IBT, interpersonal behavioral therapy, or SFT. This one I will write solution focused therapy. Please remember this abbreviations, doctors, please. Why? Because sometimes you will be confused very indefinitely, like you can't even imagine that you will forget the most common definition that you have read in your entire preparation. Questions will be like that, like just the professors can easily just misinterpret you. They can easily make you confused. What is the right answer? What is the right abbreviation? So please be thorough with these abbreviations. Even these abbreviations will damage your rank. Even these can damage your rank seriously. So please just follow these abbreviations as perfect as you can. And second one is bipolar disorder. Bipolar disorder, which can be treated with IPSRT. Sorry, it's IPSRT. Now, can anyone tell the full form of IPSRT? Anyone? It's interpersonal. It's interpersonal social rhythm therapy. It's interpersonal social rhythm therapy. Right? Now coming to the third one, stress anxiety. Stress or anxiety. So we'll just deal with some of the relational techniques, or you can also define it as relaxation techniques. Relaxation techniques. So what are some of the relaxation techniques? Something like JPMR, Jacobson's Progressive Muscle Relaxation Technique. Jacobson's Progressive Muscle Relaxation Technique. Or you can also write it down, MBSRT. What is MBSRT? Mindfulness based stress reduction technique. Mindfulness based stress reduction technique. Or sometimes you can also suggest the patient with deep breathing or diaphragmatic breathing. Yes, sometimes the diaphragmatic breathing can also be used for stress or anxiety reduction. And final one is guided imagery. Right. So these are some of the relaxation therapies that you can give regarding stress or anxiety complaint patient. Okay. Now coming to phobia, what treatments can you give to a patient with a phobia? It can be agoraphobia, it can be arachnophobia, it can be hydrophobia. Hydrophobia is seen in which condition, in which infection? Anyone? Can anyone tell what is that infection? What is the shape of the virus? Can anyone? What is the shape of the virus? Can anyone? What is this shape called? What is the shape called? I think it comes from something. No, it comes from something. From this object, something comes to outside. I think these two shapes appear similar, right? These two shapes appear similar. So it's a bullet shaped virus. It is a bullet shaped virus. Rabies is a bullet shaped virus. Okay. So hydrophobia is seen in rabies infection. So after the bite, for how many days you should check for whether the dog is dead or not? Within for how many days you should observe? Can anyone? Whether the dog dies in 14 days or not. If the dog dies, then obviously it is having, yes. So this is how you integrate a thing. And you should also know the rabies vaccination schedule, very important, right? Rabies vaccination schedule. For example, if the patient is vaccinated with rabies vaccine just 2 months before and is again got a dog bite, now what should be given? It should be rabies vaccine or it should be rabies immunoglobulin. So what should be given to the patient? So these all types of scenarios will be given in the examination. So get ready to just absorb your concepts and apply them in the exam. Okay. So when it just comes to phobia, you have two types of treatment which just help with the phobia condition. What are those two types of treatment? First treatment is something called systematic desensitization. And second one is flooding. So these are the two conditions with two treatment modalities that you can instill for phobia. Now for example, if it is a OCD condition, obsessive compulsive disorder, you can simply go on with the treatment ERP, exposure response prevention. Or if the patient has trichotillomania or dermatillomania, any of this condition, then what is your treatment for it? Trichotillomania or dermatillomania, what is your treatment? Simple. Habit reversal therapy or technique. And finally for PTSD, what you will do? Post traumatic stress disorder. What you will do? As we already discussed, we will do something called EMDR, eye movement desensitization therapy. So these are some of the treatment modalities that you can give to a patient, right? So with this we finish most of the psychiatry and if there are any in-depth topics, you please go on with it, or else if you want any topic, you can just drop it down in the comment section. Please wait, don't go, don't close, right? Still we have two more little topics which are not that much important, but still you might get a question in INICET. Okay, so we should discuss some of the important concepts regarding doctor patient relationship. Some of the important concepts. So first thing, that there should be presence of transference in case of a doctor patient relationships. Means the feelings of the patient, towards the profession, towards the professional, right? And it can be sometimes positive or negative also, right? Now if you ask me about counter transference, what is counter transference? It is the counter, reverse thing. Reverse thing means feelings of professional towards the patient. Now similarly, like counter transference, similarly like transference, the counter transference also can be positive or negative, right? Now if you ask me, what is another thing that we see is catharsis. Patient ventilates, or share or process when talking in therapy sessions. Patient feels comfortable and safer when sharing. Now final one is ab reaction. What is an ab reaction? It is an unexpected emotional outburst seen most commonly during people when their near and dear ones are no more. Ab reaction. Now the final topic is mental Health Care Act 2017. Mental Health Care Act 2017. What does Mental Health Care Act of 2017 deciphers? This may get to your exam or may not, it all depends, right? So it is actually decriminalization of the suicide by section 115 of Mental Health Care Act. So there is a decriminalization of the suicide, which is depicted by Mental Health Care Act. Okay, now followed by one advanced directive. What is this advanced directive? What is this advanced directive? Registered document with the Mental Health Review Board, which contains 3 components. There is actually a registered document which help with the registered document with the mental Mental Health Review Board, which contains 3 components generally. So what are those 3 components? Now write it down. The first one is how you want to be treated. The second one is how you don't want to be treated. And the third one is who is your nominated representative. Now how can you define a nominated representative? An adult who is nominated on behalf of the patient to take the decision, right? How can you define a nominated representative? An adult who is nominated on behalf of the patient to take decisions for him or her when capacity of thinking is lost. Now the directive is activated only when the thinking capacity of the patient is lost. This directive is activated only when the thinking capacity of the patient is lost. But all admissions in mental health established MHE should be informed to the MHRB. All admissions in MHE should be informed to the MHRB within 72 hours, because if the patient is a minor or female, and within 7 days if patient is a male. Right. So in the final point I want to tell, final point of this psychiatry, I am writing here emergency treatment, regarding emergency treatment in any hospital. For example, any hospital you take, any hospital which is not if it is not a member of mental health establishment MHE can admit and treat a psychiatric patient maximum for wait maximum for 7 hours, sorry 72 hours, my bad, wait, it is 72 hours. Okay, so this is all about emergency treatment. For example, if a hospital is not registered in the MHE, what is meant by MHE? Mental health establishment. If the hospital is not registered in it, which is not a mental health establishment, but this hospital, if a hospital is not regarded as MHE, still it can admit and treat a psychiatric patient maximums for 72 hours. Remember this. Okay, So with this we finished the complete psychiatry. I'm happy that I have finished most of the time, most of the psychiatry. Most of the MCQs will come from this PDF only. So all of you please go on with these classes. So we'll come up with the next section as fast as possible. Thank you.